Jack, you mentioned again in the RV outflow track. Are you sure you didn't mean the pulmonary valve diameter?
Yeah.
Because the RV outflow track's 40, it's 10 Miller, so 32 is not the biggest diameter.
I'm using the generic term, it's right up to the bifurcation.
Well, just because
yeah.
it goes in the because it's bigger in the outflow track.
Yeah.
Okay. And then the other thing is, I haven't seen the straight one, but the normal with the, open crowns at the top, do you intentionally try to put that as far up into the pulmonary branches as possible? Because that's a site of perivalve leak, because there's no pericardium on that. I mean, it's just on the surface, so it's open. So I just imagine some of our patients, it would potentially leak around there if you weren't way up, and so the covered part is kind of at the MPA junction. Is that kind of right or not?
Yeah, so the plan, and again, there are some patients who I think are not going to be suitable for this, but the plan is to have the flare open into the branches, left and right pulmonary artery, so that the straight part is in full contact with the main pulmonary artery, so in order to reduce that paravalvular leak concern.
Well, in addition, if I make a comment about the anatomy,
vuol dire a lui di entrare per spiegare la rotation.
You have to flare
sì, lui può commentare anche di là, c'è
il microfono lui.
Sì, sì. However, we know that right and left pulmonary arteries are not arising symmetrically from the main trunk. They arise from different directions, so it's going to be very difficult or even impossible to follow not only the size, but even more the direction of the origin of the right and left PA, right?
Yeah, and that's what's going to be challenging, because at the moment, the anatomies that we've dealt with are the ones where the branch pulmonary arteries are at a fairly similar level rather than one anterior and superior. So, yes, there will be some technical problems with that sort of anatomy.
Forse le farei vedere pure le immagini delle misure soltanto. Quindi questa e poi la misura della destra.
You could retreat this stenosis, extending this pulmonary branch in other procedure after the implantation of the venous valve.
No, con le misure.
So in you were a bit unclear before at the beginning. So were you saying that if there is a left pulmonary artery stenosis, treat it there, and then
in some condition that you could increase the pulmonary branch stenosis with the venous valve implantation, perhaps more relevant in the left pulmonary artery.
I think the likelihood is that we'll be, because of one technical problem with a pre-stented and even flared left pulmonary artery stent that was sticking into the origin, despite that, the cone would not go around the bend. And so if there is significant stenosis, I think probably the best way would be to implant the venous valve, wait for about 6 months or so, and then deal with the branch pulmonary artery stent.
Margherita?
I enjoyed the lecture of everybody very much, and I have a burning question. When you have a patient with, I don't say severe, but mild moderate pulmonary hypertension and obstruction prevailing on the regurgitation, is this a contraindication to implantable prosthesis? Is this an increasing risk factor for proper position of the implantable valve? What is your idea and suggestion?
So just say again, those pulmonary regurgitation is
mild prevailing obstruction and moderate pulmonary hypertension, which is not unusual, especially in multiple operated patients with, maybe pulmonary and MAPCAS reconstruction. You do have half or 2/3 of systemic pressure in the pulmonary beyond the obstruction. Is this a contraindication? I see that in Dr. Eiken's lecture, among the 6 patients who died, 2 did have pulmonary hypertension.
Margarita, that's an interesting question you raised, but my simple answer is we have no data or evidence of whether that's a contraindication or not. I'm guessing that these are very complex pulmonary atresias with some evidence of pulmonary vascular disease, where if the anatomy is suitable for a valve, you would still try and give those patients a competent valve. But I'm basing that on no data at all.
I think Philip wrote a paper on this, right? But it was to relieve pulmonary regurgitation in the context of some pulmonary.
Thank you. I'm sorry, because we were already earlier with the CASLab. We just have to move there. So thanks very much. Very interesting presentation. And now we try again to move to the CASLab. Do you hear us now in San Donato?
Okay. Can you hear us?
Yes, we can.
Yeah, Philip, it's a pleasure to hear your voice. Everything is okay in the main hall?
Everything very much okay, yes.
Okay, thanks a lot. So I would like to introduce our co-workers here, Dr. Luca Giugno, Dottoressa Piazza, Miriam, radiologist, and Lina and Federica and Tommaso as anesthesiologists, and Gregor, who is helping us with the 3D rotational angiography. I would like to introduce you. Luca will introduce the case, please.
The case, there is a baby, 2-year-old, weight 8, prenatal diagnosis of double out right ventricle, subaortic VSDD, and severe pulmonary stenosis. At 2 weeks of age, surgical palliation with modified BT shunt with 3 mm Gore-Tex tube. In the June 24, this is cardiac catheterization with showed moderate RPA stenosis at the level of shunt anastomosis. The baby underwent surgical repair with the transannular patch extending to pulmonary bifurcation. During the follow-up, the retarded growth and on echocardiography followed persistent of moderate RPA stenosis. Next. In this picture, you can see the right pulmonary stenosis with max gradient about 6 millimeters. So to determine severe right ventricle hypertension.
Okay, the intended procedure is to implant a Valeo stent inside this stenosis. You will find out more about this case soon. This is a picture of the Valeo stent. It is a low profile. The 6 and the 8 may go through a 6 French sheet, and they are pre-mounted, while the 10 mm goes through a 7 French sheet, and each of these diameters can be dilated up to 2 times the original diameter. So the 6 may go to 12, 14, the 8 to 16, and the 10 to 20 millimeters in diameter. This is an open cell design. Next slide, please. And so we can go to show you. We can show you what we have found till now. If you can show the pressure tracings, right ventricular pressure is systemic. The blue line is the aortic pressure, and the red line is the pressure in the right ventricle. We have also found a 10 millimeters gradient across the left ventricular outflow tract, but this is not the target of our procedure. This is not giving any problem to the child. And I would like also to show you some angiographies and 3D rotational angiographies we have done. So may I, Gregor, please go ahead with the 3D.
So what we did for angiography purpose was simultaneous injection on the left ventricle. This child was 49 milliliter, 60% contrast, so there's something like 30 milliliter contrast pure. At the same time, right ventricular injections through 6 French sheaths with rapid pacing simultaneously the same amount, so we have something like 100 cc, which is actually around 60 pure. If we take a look at the angulations Mirella will show us, then we see in blue the pulmonary artery. We cut it away the RVOT right ventricle, which is a pretty big RVOT. We did the left ventricular injection to show the coronary situation. The coronary, especially the left, is pretty far away from our region of interest when they put the stents in. It's just facing the dorsal part from the PA trunk, so no problem from the aortic side. If you take a look at this image, you probably could see that at the aortic part we see collaterals, which are of course not important, but to show you details, which are something like 0.3 millimeters. So this means what we see is real and what we see is high detail, so high spatial resolution. If you now blank the aorta away, Okay, no, no blink.
One comment we have done before, you may see a coronary artery just below the pulmonary arterial trunk. If you may show again a bit the pulmonary artery and the left coronary artery, they are quite close, so we should take into account in the future if for any reason we will need a implantation of a pulmonary valve. But this is not the problem today.
So that's one example for the topography which is visible if you use 3D like this and do all information in one run. So if we now focus on the interventional aim, which is the RPA, LPA stent, and we blank away the aorta, when we now can on the one hand side see the RPA stenosis, which probably is connected to the former BT shunt on the right, and we see that the wire is stretching up the RPA. So Jacques, addressed to you, Jacques Reshi. So of course the landmark is shifted by such a stiff guide wire, but probably it's now closer to the peri-interventional procedure relation to keep this as a good roadmap. On the left side we see this tortuous LPA, and we measured on both sides, and well, Gianfranco I think made up his plan how to treat this bifurcation situation. Last comment, we will use this PA topography now to find the best angulation or verify the best angulation he was already choosing by conventional angiography.
Okay, any comment from the audience, from the panel?
Beautiful pictures. Beautiful, I don't know. Do you hear us?
Yeah.
Do you hear us?
The microphone on? Yes.
Okay, so just a comment that these pictures are beautiful. Any other comments from the audience? Do we have anybody? John.
Ziad and I were just talking about this, and you know, just with isolated RPA branch stenosis to have systemic pressure is very unusual. And there's mild kinking if you look at the proximal origin of the left and how the left goes up and tilt, you know. So we were just talking about with someone with systemic pressure, it'd be just like what was done, I think, breaking stents that was earlier talk, could be in the Vallejo, would be a perfect good where you would stent the RPA and extend it and cross the LPA and then go through the open cell design and fix the LPA. It just, an isolated RPA with systemic pressure shouldn't be.
Well, John, I think that actually there's the more evident right PA stenosis, but the left PA as well is not normal.
Yes.
I mean, there's a great kink. I agree with you that
I think
we need to fix both pulmonary branches.
Yes.
No question about that.
John,
do you agree, Gianfranco?
Yeah, I can tell you that we have done a pullback pressure gradient across both pulmonary arteries, and even on the left side there is a 40 millimeters peak-to-peak gradient. So because probably of this angulation, we have also obtained some standard angiographies just to make to show you and to compare measurements we have done. Please show the still pictures we have done. Here you see the measurements on the right PA. The smaller part is around 4 or 5 millimeters, and the larger part of the pulmonary artery is measured at 8.2 with a length of around 20 millimeters. If we go to the left, the other picture there, please. Miriam, may you show the next picture? You may see in a moment. Next picture, please. Next still frame. Here we are. Again, we have shown in a better way the LPA, and there is anyway a discrepancy of diameter of the LPA, with a diameter going from 5, the smaller part probably even less, to 8, 9 at the distal part. But we have also done measurements by 3D rotational angiography, and we may compare the two. I think it's interesting for educational purposes.
Okay, so we would begin to encourage you to start the procedure because we have one more talk in the room.
Okay.
And if you have to do both branches, just for the time.
So you see measurements taken from 3D rotational angiography. We have around 4 in the smaller part on the left side, on the right side, with a length of 28 millimeter and a diameter of the, we may say normal pulmonary artery of around 8 millimeter. And on the left side, you may see this angulation of the left pulmonary artery. So my plan is to implant 2 Valeo stents to 8 millimeter in diameter and 26 in length, Valeo stents that may go through a 2/6 French Malin sheet with the technique of the kissing implantation by using the 3D rotational angiography roadmap as a roadmap to implant these stents.
Gianfranco,
do you agree?
Did you place 2 sheaths in the bore branches already?
Yeah, we have the 2 sheaths and 2 wires and 2 everything. I mean, just we have to implant the 2 stents if all people agrees in the audience. You may go live now. We are advancing the right Malin sheet. We are quite far, so please retrieve the dilator. Lucienne is helping me in a wonderful way, and also Luca. And now we advance the dilator and the Malin sheet on the left side. Any comment about the length, diameter of the stents to be used? Any experience about Valeo stents or other options?
Nobody getting up for
no
now.
Comments.
Yeah.
Okay, you may see the 2 long sheets. Oops, we have lost the wire.
Watch the wire, yes.
Not a good idea, okay. Okay. And we are preparing the roadmap also for helping during implantation of the 2 stents. So please take the 2 stents here on the table. 2 stent. Sì, 826.
Gianfranco,
tell me,
what stents, what size, what length have you decided to use?
Okay, so we have decided to use a 8 millimeter, I mean a Valeo stent mounted on an 8 millimeter balloon, and the length of the stent will be 26 millimeters, and we will implant two 26 millimeter stents in the 2 pulmonary arteries. Do you agree, Mario?
What would the alternative sizes be? I mean, for those who don't know the stents, what other sizes exist?
The other sizes are 6 and 10. The length is 618 for the length, and the 626, while the 8 comes in 818 and 826, and the 10 are available at the length of 17 and 26. The 10 goes through a 7 French sheet. Okay, you may see Luca preparing the stent. Please show the stent, Luca, here on the table. Okay.
Okay, we see the balloon and the stent very nicely.
Okay, we are ready to implant. Prepare the other one, please. And they can be redilated up to 2 times the original diameter. We have recently published a paper on the experience with the use of Valeo stents, and we have dilated during follow-up several of those with no significant problems. Furthermore, what we have seen in our experience is that they do not break during follow-up. There was a paper describing breakage of a Valeo stent implanted in the superior vena cava of an adult, so this is why FDA gave some alerts about the use of these stents, but actually we had no such kind of experience in kids. And the smaller kid we have treated, it has been a 2.8 kilogram baby where we implanted 2 Valeo stents, in bilateral stenosis of pulmonary arteries after truncus arteriosus surgical treatment.
So, Gianfranco, it's John.
Yeah, hi, John.
You showed the beautiful image of your pulmonary that Philip was gushing over and everything, and that's part of our modern imaging now. Are you going to use that, not just for a roadmap, but to tell you the absolute perfect angle to implant these stents on? In other words, you know, what angle did you get that on your 3D reconstruction, and then do you go back to that angle when you do the implant?
Yeah, we may decide the angle to be used. Okay. And okay, I'm advancing the stent. Sorry, a bit. Okay, you see the stent coming towards
John,
the left side.
That's very important to select the most proper projection to optimize the visualization, deployment, etc. However, the problem is when you have, well, bilateral stents, an optimal projection for one stent would be different from the other one. I mean, so I think we have to make a compromise between the two, yes.
Yeah, so what I was going to suggest is the picture that Gianfranco saw, that Philip was, you know, showed the very nice left and the right. That's probably an angle you can't get in the cath lab. In the Toshiba lab, it becomes red, so that number becomes red. That means you can't get that angle. But then sometimes when you go steep caudal, you can actually get both of these.
Yeah, that's right. And the road mapping or high pilot, as you name it, is very nice to see. But well, I would guess that we have to be careful not to be even more confused with conventional projection when using it. Particularly when we cannot achieve the perfect overlapping of the images.
Yeah. Also, when you put a second wire in, I guess. Right?
Would you comment?
The second wire, you deform the whole anatomy, I guess.
May I give a short comment on the iPilot now, which is the roadmap? So, John, you said yes, it could be helpful to choose the right angle, but to be honest, due to the big sheaths and the wires and the stents and the balloons, we have so much stiff material in the child that at this situation, every roadmap derived from 3D imaging before is without any value. So I think to get the strategy, we can choose the right level of stenosis and to treat. But now, as you see in this small child, the PAs get twisted that much that it's not really fitting to the roadmap.
Yeah, but anyway, you may see we have taken a caudal angulation with the left angulation, and anyway, the roadmap helps a bit.
Well,
what do you
think?
Gianfranco,
a comment from Gregor. You were being very polite to Gregor, saying the roadmap helps a bit. This is, if you're doing an intervention, you're trying to position stents. This is a very good example of where the road mapping is a distraction, if anything, because I bet you in your head you're ignoring the road map and just looking at the stents.
Yep. Yeah, that's right. I mean, to some extent, I agree with Jacques. I mean, be careful about the pictures. Try not to be confused. We'll rely on a conventional test angiography that we are familiar with under cases, and well, that's okay. So yeah, carry on, Gianfranco.
Yeah, I misspoke. My point was we do lots and lots of 3D rotations. The roadmap is good, like for Cork and stuff. I'm not talking about the roadmap. I'm talking about from the image that you got, what angle did you go to?
Forget the projection.
Forget the roadmap.
Yeah, that's right.
And then you use angiography, but to get you in the right projection.
Yes.
Facciamo così. Another angel. So we are just going through the standard approach with some angiographies that we should do.
Gianfranco, this is Iyad.
Yeah.
I'm really concerned about the placement of two stents to get rid of the stenosis in both arteries, because to me clearly there is significant narrowing in the LPA and the RPA at their origin. And to treat the origin stenosis, your both stents have to extend into the MPA. And doing that, you will prevent this child for future being candidate for a percutaneous valve. I think putting one stent in one branch, bring it all the way to the MPA, then go through the strut and break it to the other branch and possibly put a shorter stent there, that might be, in my opinion, a better option, so that you will not, exclude this patient from percutaneous valve in the future. So I mean, I don't know what's your comment there, because the area at the anastomosis of the branches is also narrow. You need to enlarge that with a stent, and doing the double barrel there, to me, you will have a problem in the future with this child.
Well, I think, Gianfranco, that you have to fix the origin, the stenosis of the original both branches, and
actually
concentrate on that, and we will see in the future.
Yeah, actually the main problem on the right PA, let's see the last angio. The main problem on the right PA is in the middle part of the right PA rather than on the origin. You may see in this still picture, have you seen? Come back to the previous picture. To the previous still picture, please. Previous, eccola qua. You may see the problem is mostly in the central part, where there is this sign where the previous VT shunt was in place. And if you go to the last injection I've done, last angiography, again, I think that we have a lot of room for a stent in the right PA at l'ultima angiography, and we could just put the second stent at the origin of the left PA. And I think that there is much room for PV implant in the future, but pulmonary valve is not a problem. As you may see, there is no regurg, and I mean, the pulmonary valve was not touched in this case. You see the angio, the test angio for the right PA. I should go in this position for the right PA, and then I would work on the left soon after the right is dilated. What do you think?
Gianfranco, is Oliver Stumper from Birmingham. I think your left stent is far too long. You're straddling way into the lower lobe. Also, could you tell us the distal LPA pressures? Because I share the comment that it actually doesn't look too bad to give him systemic RV pressure.
I've not heard very well, sorry. May you repeat your comment?
I think on the caudal angulation angiogram, your left pulmonary artery stent is far too long. It reaches way down into the lower lobe.
The stent, you mean?
Yeah, and
yeah, it's quite far in the. Sure, quite far.
You should really take the overlay off. It's only confusing. I stopped using it altogether because of it. Yeah,
it's quite far in the LPA. Just we make another angio here for the left side.
Yes, forget about overlaying and do a conventional angiogram in the side you want to place the
Ok, ce l'abbiamo. Siamo pronti? Ok. Okay. I mean, it's quite pale injection because of the stent, of the balloon, etc. So we can pull back a bit this stent. But first of all, I should go by treating the right PA. We are quite in a good position for the right PA. And
so what you're planning now is to put the right stent and then to take again and put the left, or do you want to put them together?
I would like again to perform an angio here, please. Ce l'abbiamo? Okay, we should pull back more on the left PA stent, if you agree with that. I think so. Okay, it looks better to me.
We believe it's good and we wouldn't go much further back.
Yeah, and we may overlap the other stent also. What do you think? Facciamo un angio qui?
I think, yeah. I mean, do you plan to put both stents at the same time or one after the other?
Yeah, we should discuss about that. What about voting about that? Precedente?
I mean, I would do one after another, but I'm kind of out of practice. I don't know. I would do one after another.
And I would go first with the right.
I would start with the right and have a look, and then do the left.
Yeah, in this particular case, when Gianfranco, this is Dr. Fontoneghi from Madrid. How are you?
Fine.
In this particular case, when you have a very big pulmonary trunk, you could inflate one balloon and after the other. Because we save this approach only we will have a severe stenosis involving the both original pulmonary branches. You have enough space to inflate without any difficulties the right and after the left. Even you can retrieve one of the stent inside the seat in order to do a very good angio. And after this, you are protecting with the wire the region of the opposite branch. We save this approach only with the severe stenosis, distal stenosis of pulmonary trunk. But you have enough space to do up to you.
Okay. So I think I should go first for the left. That is.
Elkanan, you have an additional comment?
Yeah.
Microphone to in the middle. Oh, that's okay.
Sorry, Mario.
Sorry, I'll use anyone. I just think that sometimes, now that all the hardware is in and it changes the anatomy, it's better to go to a steep caudal view and doing a hand injection there. Then you'll see the overlap much better, because you're going from this side to that side. If you just do a steep caudal view, then I think you see everything, and you'll also see the left upper lobe, because I don't think you're that far in now. I personally think the right should come back a little bit, but I think just doing a steep caudal view and then leaving it like that with the hardware in will give you the most information.
Okay.
We will take one more comment, which is coming up from Mansour,
and then we go for a stent implant.
Yeah, then you'll shut up. Okay, go for it.
Because Gianfranco should repeat the Perrine doses if we are delaying the inflation of balloon.
I think I have to go in support of his way. This is the way we have been addressing those lesions, particularly when the orifice of the PAs are very close to each other. If you put a stent invariably, the proximal part becomes proximal and makes the access to the other one is very. This is the way that we do a very adjacent lesion.
Okay, now, Gianfranco, after all these comments, it's your job. We are watching.
Okay. That's a funny part, huh? So I show you again the pictures, the angios. Okay. I think that I should go for the left first, because it's more difficult. And then if we want to adjust by leaving the balloon inside, we may deflate, but we leave the balloon inside. And then if we need to adjust the position of the right, I think it will be a bit easier. Position of the left looks okay to me. We may check again on the other projection. We may do a final check. I think it's in perfect position, and we may go for the dilation of the stent. This one, huh? Okay. Do you want to? Okay. So Luca is inflating the balloon, and I keep everything in place. Okay, go ahead. Okay, go ahead. Stop. Okay, let's see. Deflate. Okay. So we may have another angio here.
Very noisy deflation.
Yep. We may do another angio here, right? Okay, it looks better to me. So let's switch to the other stent. We do not have a biplane system, but we may do even with that. Okay. We may pull back a bit the right atrial stent, and we switch the angiographic system. Lava? Okay. I just pull back a bit, and okay. This looks nice to me as position. And we do angio, another angio here. Okay. Okay, I think we may pull back a bit this stent, and we will be ready to inflate the stent while inflating the balloon on the left side. Okay, I would do like this, I think. What do you think? Another test angio here. Okay, it looks nice to me. We need to inflate both balloons. Ragazzi, pure quell'altro. Okay, so please start together. Vai Lu, aspetta, in grafia, vai. Go ahead, go ahead, go ahead, go ahead. Please deflate. Pressure going down a bit, but now coming back. Okay. Okay. So we may do another angio here.
Okay, Gianfranco, this looks absolutely beautiful, perfectly positioned. We just, for a matter of time...
Okay, do you see, have you seen the picture?
What we would probably like to do is to give you a bit of time to do the angio, to measure the pressures and whatnot, and to have Alessandra Frigiola give her talk. So then we'll come back to you with the final result. It looks beautiful so far.
Okay, we have almost finished it, Philip. I mean, we just have to retrieve the balloons and measure proper pressures, because right now, even with the balloons inside, pressure in the right ventricle is half systemic, so probably it's less, even less without balloons inside. So we have removed the balloon now. Please give a look at the pressures here and perform a good angio, please. 12 to 10, and we show you that, and we have finished it, Philip.
Okay, just show us the retrieval of the balloon, and then we move.
Okay, have you seen so 95, 93, 95 over 50, and we may go for the angiography. Please go for the angiography, and you see the final result. Are you happy about that?
Gianfranco, congratulations, because without retrieving completely the balloon, the hemodynamic result is fantastic.
Thank you.
Okay, Gianfranco, we'll just get the results from you later then with the pressures. And either by telephone or by connection, we'll see that. Congratulations for this beautiful case. And we now have Alessandra giving us indications when one should replace the pulmonary valve.
See you.
Thanks very much. Thank you.
Thank you, and thank you to the organizers. It's always a pleasure. And well done to endure until at this time of the day. I've given this talk before, a few years ago, and while preparing it, I was thinking, what do we know now new that we didn't 4 or 5 years ago? And is